Good morning all. Hi, I am Dr. Mahendravarman, Department of Anesthesiology, Assistant Professor, Government Kalakurchi Medical College. Today we are going to discuss about the previous year neetpg questions and inicet questions about anesthesiology, and we are going to discuss everything in a crisp. I welcome you all. I welcome you all for the most neglected department in neetpg questions, which is anesthesia. You may think that only anesthesia, they have been asking some one or two questions, but even each and every one or two questions are more important. You see, for example, when you are leaving out, today you are not attending this class and you are leaving out some one or two questions, then what will happen? If you are not going to attend or if you are going to answer anything wrong, you will get a negative mark and your rank will go, even for one question your rank will go far beyond. So anything, not even a single subject is should be neglected. Everything should be attended and be attentive. I welcome you all and I thank you. Okay, then we will move on to the questions now. First of all, I had enlisted the previous year question topics which had been asked in the neetpg and inicet. In that, most of the questions had been asked in BLS, that is basic life support, and also ACLS, advanced cardiac life support. And then endotracheal intubation, after that 8 questions had been asked. In mechanical ventilation, 7 questions had been asked, and local anesthesia drugs 7, and capnography 6 questions had been asked. Oxygen delivery system had been asked 6 times, and the fluorinated anesthetic agents had been asked 6 times, perioperative monitoring 3 times, COVID treatment and protocols 4 times, and then fasting guideline 2 times, and many more topics had been asked many more times, but each all had been asked only once. So the topics will also be discussed, but most of the topics, our aim is to cover maximal coverage of maximally asked questions. Okay, then we will move on to the topics now. The first question will be, the narrowest part of larynx in infants is at cricoid level. In administering anesthesia, this may lead to all except choosing a smaller size endotracheal tube, trauma to the subglottic region, postoperative stridor, and laryngeal edema. What is the answer? Yes, right. Choosing a smaller size endotracheal tube is not the part of this thing. The narrowest part is at the cricoid level, so that while introducing the ET tube, trauma to subglottic region can occur, and due to that, postoperative stridor can occur, and laryngeal edema is the reason for that. So all these 3 things may be the reason, but choosing a smaller size endotracheal tube is not only the reason. The smaller size endotracheal tube we are choosing is because of that age, not because of that narrowest part of larynx in cricoid region. So we will see more about the adult and pediatric airways. We will see the differences. Adult and pediatric airway, pediatric will have prominent occiput, so they have to be kept, a small ring will be kept under the pillow, or directly a small ring will be kept. Tourniquet ring will get under this thing. The tongue is, this is to say that all these things, all the structures of the pediatric airway are placed one above the adult thing. The tongue is disproportionately larger in the mouth. The larynx is little bit higher. The narrowest portion is the cricoid ring. That is very much important. Narrowest portion is the cricoid ring. So what is that after effects of that? Narrowest part of the larynx in adult is glottic. This is most important thing. Narrowest part of larynx in adults is glottis. In children is subglottis or cricoid region. So small size CT tube. In a way, we can't use small size CT tube in a normal thing. Inadequate ventilation, high airway resistance, because the resistance is inversely proportional to the 4th power of the diameter. So when the diameter reduces, the resistance increases by 4-fold. When the diameter reduces, the resistance increases by the 4-fold. So when the resistance increases, the diameter increases by 4-fold. So when we use a smaller tube, there will be more resistance. Inadequate ventilation, it will also cause. Large tube, airway, if you use more than the size of the tube, then it will cause airway damage, then post-intubation group and subglottic stenosis will occur. So what to do? Appropriate ETT size for the pediatrics. How to calculate the size? For uncuffed ET tube, 4 plus age divided by 4 is a formula. For cuffed, 3.5 plus age divided by 4 is a formula. For premature neonates, 2.5 to 3 mm uncuffed. For full-term neonates, 3 to 3.5 millimeter uncuffed. For adult males, 7.5 or 8. For adult females, 7 to 7.5 cuffed are used. Okay. How to calculate the depth of insertion of the ET tube? Depth of insertion of ET tube is usually calculated by the Chula formula. The depth of insertion at the angle of mouth is calculated by 4 plus height in centimeter divided by 10. 4 plus height in divided by centimeter 10, or roughly ET tube size into 3. For example, if you are using 6 size ET tube, then the depth of insertion will be into 3, 18 centimeter. So the ET tube is fixed at 18 centimeter at the angle of the mouth. This is the rough calculation. So when I am talking about ET tube, here today we are going to have some practical demonstration also. Practical demonstration of some of the things which we are, the most difficult thing is we are going to think everything in our, we have to imagine it, then we have to mug up, then you have to write. That is the most difficult part of this neetpg. But when we see something, when we hear something directly, then that remembrance will be more better. So we have some practical demonstrations today. So when I had been talking about ET tube, so this is ET tube. Can you see, everyone? This is ET tube. This is cuffed one. This is cuffed one. This is called pilot tube. You see, parts of ET tube is also asked in one of the previous year questions. Parts of ET tube, image based questions. So in ET tube, this is pilot balloon with valve. You can see that. Here it is the universal adapter. Here it is the pilot balloon. Here it is the cuff is there, and here it is patient's end. Here it is machine's end. In this patient end, here you can see a small hole in the sideways. This is called Murphy's eye. Can you see that? Murphy's eye. It is more important. They will ask, what is this thing? Murphy's eye. Why there is Murphy's eye? If there is any obstruction while we are intubating, then the ventilation will be done with this Murphy's eye, which is placed side beyond. That is the purposeful of this Murphy's eye. Also, we have one blue color line. Also. This radio opaque line. It is radio opaque line. The important purpose of this radio opaque line is when the patient is intubated in ICU, or when the patient is intubated, to check the position of the ET tube. After intubating, we will take one X. There are many ways to confirm the position of ET tube, which we will see further. There are many ways to see the confirmation of position of ET tube, and one of the thing is taking chest X-ray in an ICU patient. While taking chest X-ray, this radio opaque line will show you the path of the ET tube. So this is a short thing about the ET tube. This is cuffed one. We also have uncuffed tubes also. This is markings. This is the markings. So you see, this is 8 size ET tube. This is 8 size ET tube. According to this, we can roughly place it at 8 cross 3 or 8 cross 2.5. It can be placed at 20, 22. Right. Here it is. Centimeters have been marked. 20, 22, 24, 26. We have been marking the centimeters for fixation of the ET tubes. Okay. That's all about the ET tube. So next thing. Before moving on to next thing, we had been in the modern era of medicine. We had been going through many things, and we had been developed many things. And in this process of development, we always forget the legends and the pioneers of the medicine department and everyone. It's happened. We also used to forget. No, but that should not happen. You see, for example, there is one difficult part. There may be one difficult part for everyone to study in neetpg. What is that? The most difficult part will be remembering numbers, remembering years, remembering scientist name. You see, if anyone asks about a scientist name, if anyone asks about a year, you will get irritated because it's very difficult to remember. But one thing you see, that one scientist will put on his whole life, to discover one thing or one or two things. He will sacrifice his entire life to discover that one thing. But spending 2 to 5 seconds to read that scientist name will be much difficult for us. So we should think of that. That colleague of ours had put his whole life on making this thing happen or to discover the thing. So we should not be hesitant. We should not hesitate to remember his name. So we should remember. What will you do? We will remember our by giving tidis. By giving tidhi, we will remember our olden days fathers, grandfather, like that. So we have to also remember this thing. Who is this gentleman? I want to know. Who is this gentleman? No problem. We'll move on further, then we'll know who is he. Which of the following denotes modified Malamati grading 3? Only soft palate and hard palate is visible. Soft palate and base of uvula is visible. Only hard palate is visible. Passes hard palate, soft palate and uvula is visible. This is the tricky portion. This is the tricky question actually. And immediately what we will say? Malamati grading 3. Immediately we will do what? Only soft and hard palate is visible, like that we will do. But this is not correct here. Actually the answer is soft palate and the base of the uvula is visible. This is the correct thing. I will explain how. You see, you won't remember this. You won't remember this colleague of ours. But you can remember at least this gentleman. You know this gentleman? Who is he? Tell me, who is he? Yes, Allu Arjun from Pushpa. What is the relationship between Pushpa and Malamati? What is the relationship between Pushpa and Malamati? Yes, there is some relationship that I will going to relieve. You see, for remembering Malamati, modified Malamati grading, Pushpa is the mnemonic. Pushpa is the mnemonic. You may forget about the scientist, but you will never forget about Pushpa. You see, Pushpa. You can write like this. So, P for pillars, U for uvula, and S for soft palate, H for hard palate. So, pillars, uvula, soft palate, hard palate. That is Pushpa. So, modified Malamati grading Pushpa is a mnemonic. Okay. How will you? This is generalized thing, but they will be more specific sometimes. Like this question we had seen just before. You see, in modified Malamati grading in MPC 1, everything is visible. Pillars, uvula, soft palate. In 2, strike out this. Uvula, soft palate, hard palate will be visible. In 3, soft and hard palate will be visible. In 4, only hard palate will be visible. This is generalized thing. But to be more specific or to be more precise, there is something. You see, now we will see more precise. Modified Malamati grading 1, everything is visible. In 2, this is 2. In 2, partial pillars are not visible, and also the tip of uvula will not be seen. Tip will be not seen. In 2, tip will be not seen. In 3, soft palate, hard palate and base of uvula may be seen. In 3, soft palate, hard palate, base of uvula may be seen. And in 4, strike out all these things, only hard palate is seen. Now tell me, who is this gentleman? He is Mr. Sheshagiri Rao Malamati, who gave us the Malamati scoring for airway assessment. Now you just remember. So Malamati grading, it is Sheshagiri Rao Malamati, or you either remember Pushpa. This is the Malamati scoring. So in 1, partial pillars will be seen, soft palate, hard palate, uvula will always be completely seen. In 2, the tip of the uvula, this is the tricky point. 2, tip of the uvula is not seen because the tongue moves up and up. The tongue moves up, so that first it will hide the tip of the uvula in 2. It will hide the uvula and tip of uvula in the 2, MPC 2. And in 3, soft palate, hard palate will be seen. Along with that, sometimes base of the uvula. Base of the uvula may be seen. Tip of the uvula not seen in 2. Base of the uvula will be seen in 3. And 4, only hard palate. Or in general, all 4 Pushpa, all 4 visible. In 2, uvula, soft palate, hard palate. In 3, soft and hard palate. In 4, hard palate only will be visible. Hope you will remember something about Pushpa. Okay, we will move on to next question. The steps of intubation in sequence. Inicet November 19. I already told that intubation had been asked some 8 to 10 times it had been asked. So it's very important, the steps of intubation. Here, neck extension and flexion, introduction of laryngoscope, inflation of cuff, checking air entry by stethoscope. Yes, tell me the answer. Yeah, correct. Answer is A. But next extension and flexion will be done. Then introduction of laryngoscope, then checking air enter and inflation of cough. Sometimes the D and C may be interchanged. You don't confuse. This is either A, B, D, C. If they are given like A, B, C, D, if there is option called A, B, C, D, it is also correct. A, B, C, D is more correct actually in this question. So first you are extending the neck of the patient. First you are extending the neck of the patient. Then you are introducing the scope, and then you are intubating, and then you are intubating the patient, and then what will you do? We will check for entry, we will put for the cuff, and then we will ventilate, start ventilating. This is the steps of intubation. You see, there is another more important area in this intubation. What will you do? What will you do for positioning of the intubation? That is morning sniffing position. What is it called? Morning sniffing position. How will you sniff? Ach, like that we will sniff, ach. So it will be like this for intubation, morning sniffing position. It is like that. So there will be extension at the atlanto-occipital joint and flexion at the cervical spine joint. Here comes the tricky part. There is tricky thing in every question. There is easy thing in every question. Likewise, there is tricky thing in every question. Here in this question, the tricky part is where will you do flexion? Where will be the extension will be occur? Most of the time, I will be reading many times. But when on the table, while writing exam, I will forget. Most of the people will do like that only. They will forget, or they will have some small confusion whether the flexion occurs at here or the flexion occurs at there, extension occurs at here or not. What I am saying is flexion at atlanto-axial joint, extension at atlanto-occipital joint. You see, atlanto-occiput, oxy. So when you are saying oxy, it is extending. Your mouth is extending. So extension at atlanto-occipital joint. Atlanto-occiput extension, atlanto-axial flexion. Atlanto-axial flexion, atlanto-occiput. It is extension. Extension at the atlanto-occipital joint, extension, and atlanto-axial joint, flexion, or flexion at cervical spine area. This is the most tricky point, so you should not do any mistakes. Then comes the rapid sequence intubation. Earlier we had seen about intubation. Now rapid sequence intubation. What is rapid sequence intubation? We will see. The options are pre-oxygenation with 100% oxygen for 3 minutes, muscle relaxant and inducing agent given simultaneously, preferred for cardiac arrest patients, tubes with low pressure and high volume cups are used. Yes, tell me the answer. Yes, muscle relaxant and inducing agent given simultaneously is false. It is not given simultaneously, it is given one after the other. So what are the important things? Pre-oxygenation is must. Pre-oxygenation for any patient is must. Pre-oxygenation is must. Then mostly we are preferred for cardiac arrest patients or any emergency procedures. We are going to take emergency procedure. We have no time for detailed thing. Then you have to cut down a short, like we are doing now. We will having a detailed class. But since we are nearing exam, we don't have time. So we are doing a cut short session. Like that, if you have time, you will do a detailed proper intubation. If you don't have time, we will have rapid sequence intubation. In that rapid sequence intubation, any intubation will be done with low pressure, high volume cuff. Remember this thing, pressure is low pressure, but high volume will be given. With this cuff, high volume will be given. Why? Because if you give high pressure, if you give high pressure, then stenosis or necrosis will occur, tissue necrosis will occur. If you give high pressure, tissue necrosis will occur. That's why we designed like this. Low pressure, high volume cuffs, soft cuffs here, design this thing. This is rapid sequence intubation. First, you have to prime the patient that we are going in this rapid sequence intubation. What we are going to do is Sellick's maneuver. This is most important. Sellick's maneuver. We are going to give pressure about the cricoid ring. To prevent aspiration. To prevent aspiration. Normally we don't do this thing, but we are doing RSI or any emergency intubation. It will be done by one assistant. Then the assistant, first you have to explain that we are going to giving pressure over the cricoid ring. Why cricoid ring? Selix maneuver done over the cricoid ring. Why cricoid ring? It is a complete ring which will obstruct the hypopharynx or esophagus so that the food content in the esophagus will not aspirate or come out. That's why we are giving Selix maneuver. So we will tell the patient shortly. You see, so and so you will. We are going to giving slight pressure over here. So don't panic. Like that, you have to prime the patient. Then you have to give pre-oxygenation for 3 minutes with 100% oxygen. Or if you don't have 3 minutes, also we can ask to take the patient 8 vital capacity breaths. If the option was not given us the 100% oxygen for 3 minutes, then look for 8 vital capacity breaths. So 8 vital capacity breaths, if the patient takes, it is equal to pre-oxygenation with 3 minutes oxygen. Then you will give pre-medications. Pre-medications like glycopyrrolate, an anti-anxiety like injection midazolam, and any mild sedative opioid, injection fentanyl or fortune like that. Then we have to give cricoid pressure, Selix maneuver with the trained assistant, Selix maneuver. Then we will, there is something called burps maneuver, burps maneuver. What is burps maneuver? What is burps maneuver? Burps. It is backward, upward, rightward, and posterior. This maneuver, burps maneuver, is done for making the vocal cord better visualization. You see, Selix maneuver is done to prevent aspiration. But burps maneuver is done for better visualization of the vocal cord. Visualization of vocal cord. Burps maneuver. Backward, upward, rightward pressure. It is also given by some assistant, and Selix also given by some assistant. Okay. After inducing with either thiopentone or propofol or ketamine something, then we'll give succinylcholine. We'll give succinylcholine 100 mg so that the patient gets muscle relaxed. Then we will intubate, and then we'll confirm the ETT tube placement by auscultation or seeing fog over the air in the ET tube. Then after that, after confirming the ET tube placement, only we have to release the pressure. Till then, the Selix maneuver is continued to prevent aspiration. Then after that, post-intubation management is everyone according to the patients, what for the patient had been coming, what for the illness for is coming, we have to treat accordingly. Okay. While discussing this thing, while discussing about the pre-oxygenation, I have to mention some more important things. We all know that. Pre-oxygenating patient is not actually we are pre-oxygenating the patient. It is denitrogenation. They had sometimes they asked about this denitrogenation. Denitrogenation is nothing but pre-oxygenation. Actually, what we are doing is we are removing the nitrogen. We are inhaling the room air. You see, we are inhaling the room air. What is presence in the room air? In the room air, 21% oxygen and 78% nitrous and trace gases will be there. Likewise, when we are inhaling in our lungs also, most of the gases, most of the volume will be filled by nitrous. Only 21% will be filled with oxygen. So when any patient become unconscious, when any patient is not breathing at all, then the 21% oxygen will be present. The brain will start using the 21% oxygen, and then oxygen from the dissolved oxygen from the blood it will use. So it will be very much less amount. So to make more available of oxygen, what we are doing is pre-oxygenating the patient, or denitrogenating the patient. Means pre-oxygenation is nothing but denitrogenation of lungs. Okay, I am going to tell the most confused part about this thing. Here comes the lung volume and capacity. You everybody know Everybody will know about the lung volume and capacity. You will be reading very much nice, but just before the exam, you will forget everything. Just before the exam or just on table of the exam, you will forget everything. I will tell how to remember this thing easily. Lung volume and capacity. You see, normal inspiration and expiration is tidal volume. Normal inspiration and expiration. This is tidal volume. Okay. Whatever we are breathing more above than the normal inspiration is inspiratory reserve volume. Like this. This is inspiratory reserve volume. This is tidal volume. So if it goes above, this is inspiratory reserve volume. Likewise, after normal expiration, we will forcefully expire the remaining air out of our lungs. That is expiratory reserve volume. You see like this. Like we are forcefully expirating extra volume after the tidal volume. That is called expiratory reserve volume. This is inspiratory reserve volume. This is expiratory reserve volume. But remember one thing. Even after forceful expiration, there will always some amount of air will be remain inside the air. That is called residual volume. That is called residual volume. That is called a residual volume. It is like savings in your bank. That residual volume is like savings in your bank. So whenever you are in crisis, the oxygen from that residual volume and expiratory reserve volume will be used by the brain. So both this thing, expiratory reserve volume and residual volume, is known as functional residual capacity, X4C. Functional residual capacity. It is the most important thing to be remembered in the physiology and also in the anesthesia. Functional residual capacity. So some questions they will be asking like this. Sometimes you will see they will ask what is vital capacity? What is vital capacity, or what are the things that made vital capacity? What are the things, which of the volumes will be combined to TC to make FRC? Or total lung capacity, what are the things which will be combined to form volumes and capacity? Like that they will ask frequently. You would have read well, but still there may be some little confusion. I am going to tell one thing. Which will remember you, which will make you remember forever, even in your sleep. When anybody asks you, how will you tell this answer? You will answer that. We will make it simple, right? You can remember like this. You can write it as ready TV, ready, then TV, ready TVI. Left side it is ready, right side it is TVI. Okay. Then left side is the lung volumes. Left side is the lung volume, right side is the capacities. Left side is the lung volume, right side is the capacity. Now see, this is tidal volume and inspiratory reserve volume combined to form inspiratory capacity. Right side is the capacity. Tidal volume and inspiratory reserve volume will combine to form inspiratory capacity. Along with this inspiratory capacity, when expiratory reserve volume combines, it will form vital capacity. So vital capacity is expiratory reserve volume plus tidal volume plus inspiratory reserve volume is vital capacity. Along with this vital capacity, when residual volume combines, it is called total lung capacity. Along with this residual volume plus vital capacity will form total lung capacity. So this is the thing. Again I will explain. Don't worry. This volume, lung volume and capacity is the most easier one. Also, it is the most difficult one to remember. You can easily read, but you will forget. So, left side, you are going to write about the volumes, and right side, capacities. So, left side, you just write ready. Right side, you just write TVI. So, tidal volume and inspiratory reserve volume combined to form inspiratory capacity. This side fully capacity, this side fully capacity, this side fully volumes. So tidal volume and inspiratory reserve volume forms inspiratory capacity. If expiratory reserve volume combines with inspiratory capacity, it forms vital capacity. And if residual volume combines with vital capacity, it forms total lung capacity, which is 5 to 6 liters. Total lung capacity, which is 5 to 6 liters. Okay. Where is the FRC? That is the unusual thing. FRC will come here. Residual volume and expiratory reserve volume is FRC, the only capacity which comes in left hand side. Okay. So is it clear now? Is it clear now? Please use this mnemonic and try to remember this thing. So where we had gone? We had learnt about intubation. Steps of intubation, then rapid sequence induction and intubation. In that rapid sequence intubation, we learnt about pre-oxygenation. In that pre-oxygenation, we learnt about denitrogenation also. In that denitrogenation and this thing, Sellick's maneuver and Burp's maneuver. Sellick's maneuver and Burp's maneuver. Sellick's maneuver applied over the cricoid ring, released only after confirmation of ET tube. Burp's maneuver done for better visualization of the vocal cord. Sellick's maneuver done for preventing aspiration. Sellick's maneuver done for preventing aspiration. Burp's maneuver done for better visualization of the vocal cord. The vocal cord visualization will be scored by Cormack-Lehan scoring. Cormack-Lehan scoring, it is 4 things. 1, 2, 3, 4. Cormack-Lehan. 1, 2, 3, 4. When the Cormack-Lehan is 3 visualization, after applying Burp pressure, the Cormack-Lehan 4 will be converted to Cormack-Lehan 2 or 1, and better visualization of the vocal cord and intubation will be very much easier for us.